Hi everyone, welcome to another Wednesday VMR. Thank you so much for joining us. Sharmin here. I'm super duper lucky to be joined by Zakariyya, who is finishing up an ICU rotation and still making time for VMR. You all amazing. Thank you so much for being here. How are you doing, friend?
Hi everyone, I'm Zakariyya G. Really excited for the case. Yeah, I think Sharmin told me about it about a month ago, and I've been sort of counting on the days. So really excited to learn, and I think we have a new presenter, if I'm not mistaken. So yeah, really excited for that.
Absolutely. I'm super excited for this case. Big shout out to David for doing scribing. Thank you so much, Hans, for doing teaching points. And Sunayu, do you want to say hi to everyone?
Thank you. Hi everyone. This is actually my first time presenting here, so there may be some times where I may get too excited and make our subscriber a little too busy. So please feel free to tell me if anything that ever happens. Okay.
Oh, well, we're very excited. Hopefully, this is the first of many. Sunayu, thank you so much for being here. And if we can get the board up, then we can get started. Thank you, David. All right, Sunayu, the mic is yours.
Okay, so we have a 37-year-old male who presented with a throbbing headache and nausea that he had never experienced before. And it just started a few hours ago when he woke up. So um, he called his primary care for this throbbing headache and nausea, who told him to seek urgent care. So he walked himself to the ED. And at the ED, of course, we took his vitals, and um, in the ED, we had his heart rate at 130, with his blood pressure being 220 over 120. So he also described a little bit of shortness of breath, and we also got an EKG here, which showed left ventricular hypertrophy. And other than that, the EKG wasn't too remarkable. So I wanted to stop here briefly to hear some thoughts, and yeah.
Oh, amazing. So a couple of things just to start off with. I think the first thing when you mention somebody had a headache is we all automatically start thinking about red flags, right? And immediately the patient's, well, we don't know if he has a past history of any headache syndrome, but the fact that it seemed to be acute in onset is a one red flag. The fact that it's throbbing in nature, I translate that into something being pulsatile, and it automatically starts making me wonder about what sort of issue inside a blood vessel in the brain can be happening. And the fact that it's associated with nausea and was severe enough to wake him up. All of those are real red flags and make me seriously concerned, which is not usually the base rate of most people who have headaches, which are usually often relatively benign in terms of their causes. Once we go from there, when we talk about the vascular issues in the brain that can cause headache, there's so many things that can happen to a blood vessel that can cause the sort of thunderclap onset headache. Now, I know the classic definition is that thunderclap headache tends to happen over seconds to minutes, but usually not hours. That's not always the case. You can have a cause of a thunderclap headache that can sort of start slightly more gradually and then get worse with time. In terms of what can happen to a vessel, vessels can rupture, they can be spasm, they can dissect, they can have an aneurysm. There's so many different things. And most of the time, any sort of vascular pathology will cause this syndrome. The one other thing to them that I really paid attention to, and it was interesting because I was actually talking to one of the nurses in the ICU this morning when he told me that the patient had high blood pressure, is I went on sort of my soap rant about how hypertensive urgency is not something to be taken seriously. But here we hear both neurological symptoms and this patient having shortness of breath. And I start to wonder, could there be a relation where is the blood pressure the cause of both? Has the patient had, for example, a hypertensive bleed, and they're having sort of what was previously known as flash pulmonary edema? The new term is sympathetic crashing acute pulmonary edema. And that's one of the things that I wonder about. And then the other thing I wonder about is, could this patient be having something like posterior reversible encephalopathy syndrome? And then I just think the last thing is the fact that he was able to walk to the ED is interesting, as I think many of the causes of a severe thunderclap headache in the brain would sort of cause some focality with neurological symptoms like weakness. And I think one of the causes that I associate with a thunderclap headache that does not necessarily always have those focal neurological signs is a cerebral venous sinus thrombosis. So I think that's where I'm at, and I think it'd be so interesting to know more about the patient and what his past medical history is.
Oh, that was beautiful, Zachary. I really loved how you're thinking about like when to worry about a headache, what like the vascular pathologies that you worry about, and kind of what is the link between the hypertension and possibly like the headache. And press is such a great thought in anybody coming with like elevated blood pressure, thinking about sinus venous thrombosis as like a no misdiagnosis is absolutely fantastic. Yeah, I think like kind of the big question at this moment is that like, is this like a primary or secondary headache? And with that elevated blood pressure, my new misdiagnosis, are we worried about like a hypertensive emergency, and we're seeing end organ involvement because of the elevated hypertension? So few things that kind of, as you're seeing a patient like this, is really important to establish, like, does they have any underlying history of hypertension? He's 37 years old. He's like quite young. Has he seen by doctors before? We already know that in the ECG has evidence of LVH, so that might be long lasting. However, in young people, sometimes in ECGs, people do have like the LVH morphology without actually having LVH. So something to kind of think about if there is any underlying and how much off his baseline this is. But let's just assume this is the first blood pressure we ever have of this patient. Still quite high. And whenever people present with like really elevated hypertension, elevated blood pressure, and kind of like a headache, a couple of things, making sure we get that non-con head CT sooner than later, because hemorrhagic strokes definitely can happen even in the young adults. And the other things you always want to make sure is there any other end organ involvement? We're having the shortness of breath, as Zakariyya mentioned, like flash pulmonary edema. The other things like, troponins, kidneys, can also be involved. So getting your full set of labs. And then the question is like, okay, why is this patient so hypertensive? I think like once you establish like this is one of the times that you might also want to think about like both managing and your differentials at the same time. Oftentimes in older people that we see, a couple of things that you always like want to make sure. If people are on severe pain, like urinary retention, severe constipation, these things in older adults oftentimes can present really elevated blood pressure. And as soon as you relieve the issue, they get better. So also always being mindful of what acute triggers can cause really elevated blood pressure, so we don't subject everybody to $1 million workup. However, in a young 37 years old, that's probably less likely. So the things that I would like worry about in this one is like, substances, like especially like stimulants, cocaine, those things that can cause like elevated blood pressure, withdrawal from substances, as well as then a lot of the endocrinopathy that I'm sure that we're going to get into more that can cause like really elevated blood pressure. And then you also want to again be mindful of like vascular complications of elevated blood pressure as well, like dissection being one of them. So it's very intriguing. I'm like very curious to hear more about his like background, and like more of an exam and some lab funding to help us make more progress. Anything else to add, Zakariyya?
Absolutely nothing at this moment. Yeah, that was amazing. And yeah, just really need to know more about this past medical history, or is this his first presentation? Yeah.
Yeah, I'm so glad that everyone was thinking along the same way that I did. So, one of the major concerns of the timely matter was, would this patient have some sort of brain damage? So we did get a non-contrast CT at the ED very quickly, and it did not show any signs. It was rather unremarkable, was what the reading said, but it wasn't significant for the ruptured aneurysms and the what we would call acute neurologic symptoms. So that was one of the glad things. And yeah, so going on with the history of the present illness, he did have, on asking, he did say that he was diagnosed with hypertension. So he did get some anti-hypertensive medications, but per patient, he ran out of them a few weeks ago, and then he had a very, I found it an interesting regimen for the anti-hypertensive medication. He was on amlodipine 10 milligrams and hydralazine 10 milligrams, but he ran out of them, so he wasn't taking them at the moment. As for the headache, he said it did get worse for the past few hours, but he wouldn't describe it as something that would bother him to walk to the ED. So that was one of the reasons why we thought maybe that has to do with the high blood pressure that he has. So with the headache, we of course asked him if he felt any palpitations or any sweatings. He did not say that he had any of those. As for the review of the systems, there wasn't much except for the headache that he made him come to the ED at the point. For the physical exams, he described his headache as 7 out of 10 in severity, but he tried acetaminophen, but he didn't get any relief from that. So moving on to cardiovascular, we started him on a nicardipine drip because, well, his blood pressure was very high. As for the pulmonary edema, we were very concerned, especially with the shortness of breath. So we listened to his lungs and it was clear without crackles, which was good. For the GI symptoms, he was feeling nauseated, but he didn't vomit. He didn't have any diarrhea or constipations. As for the extremities, we were concerned that he might have weakness, but he didn't, and he had no edema appreciated. His BMI was within the normal range, and I would like to stop here and get some more opinions here.
Should I start? And sure. Yeah, so I think the first thing is most likely, because this is a CPS case, that there will be some unusual cause of secondary hypertension. I think just for us, like our population in South Africa, we have such a high prevalence of primary essential hypertension in younger and younger patients. And I've gotten at times quite excited about doing these secondary hypertension workups, thinking, it's going to be something unusual. And it's actually often times been negative. So I think the first thing is the point that was taught to us is when you are thinking that somebody has a cause of secondary hypertension, just know that you should do the workup at certain points. So when somebody starts to have signs of serious end organ damage, that would be one of my indications. When somebody has exceptionally persistent hypertension despite being on multiple medications and being adherent to them. And I think the other thing is when there are unusual clues that something doesn't just fit in with essential hypertension. So for example, if you have somebody who has chronic renal failure that's young with CKD, and yet their potassium is persistently on the low side, for me, that would then be an indication to work up primary hyperaldosteronism. I know some of the indications now, I think in some more resource-rich settings is that anybody with essential hypertension gets worked up for it because about 10 to 15% of the population with so-called primary essential hypertension will actually have it as a cause. But I think just my point is when you are doing a secondary hypertensive workup is to not just be blanket and tick everything on the box, is to start off with a pulse exam, make sure there is true adherence to treatment, and then start to be sort of targeted. So for example, while hyperthyroidism can definitely cause secondary hypertension, I'm not I suppose a TSH is sort of part of a basic workup, but I think my pretest probability of the patient having roaring Graves' disease is actually relatively low, because I think if this patient did have Graves' disease causing this, you would see other things. The patient would have been losing weight, he would be extremely diaphoretic, I would have been potentially hyperthermic, and perhaps other clues on physical exam. Yeah, and I think perhaps that respiratory distress was a relative red herring, as the lung exam sounds normal. And I'm not sure if we heard it, but it didn't sound like his oxygen saturations were abnormal either. And I think that's just with regards to the secondary hypertensive workup. And then for me, the one other thing is I would have to go check up and read on the sensitivity of imaging for the sort of thunderclap headache syndromes. But I definitely don't think we've exonerated it just by having a non-con CT. We might have ruled out a massive bleed, but I think if you started to push further, for example, going to CT or MRI venography, you definitely could have a cerebral venous thrombosis that won't show up on a non-con CT. So yeah, I think potentially I would want to start looking for clues for secondary hypertensive workup, and then also to start to consider whether this patient needs further imaging of the brain.
Yeah, I really, really love that approach, Zakariyya, especially thinking about like kind of like where you practice the base rate of disease that you see, and kind of like what is like a high value care in terms of like your workup. Yeah, I really, really appreciate not doing like the $1 million workup on everyone, as you mentioned, is often not needed, and you want to look for clues to see where it's going to be the highest value added. And I think in this case, I agree with you, Sunayu. I'm a little bit puzzled by the medication choices. I think like hydralazine 10, I usually don't think about it as a daily medication. Oftentimes it's like a TID medication. And oftentimes it's not like kind of the best first line medication that we use these days. And the amlodipine, like great medication. And I'm curious, like I think like a couple of things in the background that would have been the times it's not, is that like well, like how high were his initial blood pressure, for example? Did medication present on his, as Zakariyya mentioned, is that some level of control when he was like placed on this medication? Because oftentimes like one of the reasons people present with acute hypertension is like kind of like withdrawal and getting off of the BP meds and not taking them. However, these are not like highest dose medications and like highest levels that I've seen. And the relative presentation with the elevated blood pressure, it makes me think that it's probably less likely, and there might be like another trigger that we haven't missed. I would still like just make sure to get a detox, get a health behavior history, especially with like I mentioned like alcohol, those things we often see in the younger folks, like we draw from opioid example of chronic pain background that that's not treated, that he's like that's led to like kind of more substance use disorders. We see that a lot in our patient populations. And the other thing is, as Zakariyya mentioned, as we as we see this patient, if he has developed like a bit more encephalopathy, and like definitely like having a low threshold to getting that brain MRI, I totally agree with that. But I think like once he's like started on the cardipine treatment, it would be really informative to see if his headaches get better with and with the treatment that you're giving him, that if it is true just a side effect of this elevated blood pressure, or there's another sinister cause that it's that is lurking in the background. Really want to like commend you for starting a drip on this patient. Whenever you're worried about hypertensive emergency, drips are your best friend. That allows you for the finest control possible. At times, like I remember people used to put like nitro paste on. We give like IV medications, oral medications, and you really, really want to be thoughtful and gentle when you're lowering this blood pressure. You don't want to really lower it more than 20-25% for hours, and like gently bring them bring him down. So I think like drips are like the best way to do it and the safest way to do it, and like how we respond to it would be really informative. I agree with you, Zakariyya, in terms of like endocrinopathies and like likely and TSH, we're probably going to get it less likely for this to be Graves' disease. If this is more turns out to be episodic, then like pheochromocytoma again is like quite rare, but oftentimes the one that we think about. You mentioned the hyperaldosteronisms, and the one thing that I'm like in my mind and I'm looking for is like his creatinine and a UA. A lot of like kidney diseases oftentimes can present with like really elevated blood pressure, and one of the no misdiagnoses here are like your glomerulonephritis, your TMAs that can definitely do it. And the other thing that, in a misdiagnosis that I always have that scares me is a dissection and people who have really, really elevated blood pressure. So his kidneys are okay. At least like, the bilateral blood pressures are not the most helpful. But he doesn't sound like he has any tearing chest pain to the back. But dissection sometimes is like PE is like a little bit hard to catch. So like I have high degree of suspicion for it. And then some of the other neurological disorders that I often think about that present with really elevated, like strokes, elevated intracranial pressures. And nothing else is like pointing us toward that direction. But again, I think the neuro axis, as Zakariyya mentioned, if it's not getting better with lowering the blood pressure, definitely requires like further investigation. Anything else from your perspective, Zakariyya?
Nothing at all. It was amazing.
All right. So now back to you. What are rich kids?
So those were all the concerns when we were taking care of the patient. So we did have the neurology on board for quite some time, and we were monitoring his headache while we lowered the blood pressure, and we weren't able to get the baseline blood pressure from the patient, but as we lowered the blood pressure, he kept on saying things. We weren't very hard on him. We were going very gentle with the lowering of the blood pressure, but he still complained of being very lightheaded while we lowered the blood pressure. So we were thinking maybe he was very used to high blood pressure. And so we tried probing for some other histories like family history. And one thing that was very intriguing was that he has a younger brother with a kidney failure in his 20s, and he got a kidney transplant at age 30. So our patient is very young, but he has even younger brother who got a kidney failure and a kidney transplant. So I found that was something very intriguing. And we got his initial labs with the sodium being 135, potassium being 2.9, yeah, and chloride was 97. And as for bicarb, we had 20. It was within the normal range, and we had the creatinine of 8. And we had 3 years ago, it was 1.5. And the protein creatinine ratio was 1.61. The urine protein was 113 milligram per deciliter. And we did get the troponin, urinalysis, and urine toxicology screening. Urine toxicology panel was all negative, which was quite surprising because this patient was from an area with a lot of drug users. With the urine lights, we had, the troponin level was elevated at 4, and the urine lights were sodium of 90, potassium of 14, chloride of 97, and his CBC was quite unremarkable. And yes, we did cast a broad net, and we did get the free T4 which was within normal range. Yeah. So yeah, we got some labs, and I do want to hear some ideas here.
Oh gosh, this is so intriguing, Sunejo. I think Firstly, I'll come back to the past medical history, but I spoke about it earlier, and here's a patient who you have a reason to do a renal and aldosterone, even if you're in a resource limited setting like I am. This patient has acute renal failure, it seems, or well, he has presumed acute renal failure, as you should always make that assumption until proven otherwise. And yet he has an unusually low potassium, and that to me is unusual. But what I do find interesting is that in somebody who has primary hyperaldosteronism, aldosterone should cause sodium retention, and I would have expected quite a low sodium in the urine. But however, there is a confounding factor here that if this patient has had tubular damage, even though aldosterone might be appropriately elevated or inappropriately if he has a sort of Conn syndrome, the kidneys might not be able to respond to that aldosterone. And that's why you might have a high sodium in the urine as sort of a consequence of chronic Conn syndrome with resultant CKD. I think the other thing then just to know is that the potassium can be a total bystander. This patient has signs of sympathetic toxicity with severe hypertension, severe tachycardia, and when you have your catecholamines in overdrive, it pushes potassium into the cells. So I'd be wondering, is the potassium persistently abnormal, or was it sort of just a once-off abnormal lab value? And then I think the troponin, I'm not sure how high that is. I'm not familiar with the units. It could just be explained by the patient's renal failure, or is it really something to do with the heart? I think then just coming at, we've previously had a case of Fabry disease on VMR, and I remember the patient had a family history of siblings who had renal failure and can also cause hypertrophic obstructive cardiomyopathy, which might explain the fact that he has LVH. I'm not sure if that was just seen on an ECG, if that was also on an echo. So I'd wonder about that, and then I'd have to broaden my horizon to other genetic diseases associated with renal failure and severe end organ hypertension. Yeah, I think that's where I am, and I'm curious what else you have to add, Sharmin.
Oh, that was such a beautiful analysis of the urine studies and invoking kind of hyperaldo. Because, yeah, if somebody's coming in with like creatinine of 8, oftentimes what happens when you have an AKI, you get hyperkalemia. And in this patient, you're getting hypokalemia. And that's odd. We heard like he was like having some nausea. So we can like invoke some like GI losses if it was like vomiting a lot. But that is oftentimes but that is oftentimes like that's not what we heard. So yeah, the fact that sorry, I got this like random message. So again, so if we're not having any upper GI losses, then I think like invoking the hyperaldo or an appropriate aldo schema is very correct. And as you mentioned, like getting that aldo and run in. And also like while we're doing that, just like kind of not anchoring and thinking about like what other etiologies can present. I think the hereditary etiologies, as you mentioned, is quite apt to think about in someone who has kind of a big family history of like people with end-stage renal disease. It would be really interesting to know what was the diagnosis for the brothers, because if we think about like, in certain population, end-stage renal disease, it's not uncommon. Severe CKDs are not common, and the path to CKD, like from metabolic disorders to insults that are not retrievable, is actually the differentials are quite wide. So so I would be curious to see like, was it the same reason? Was it like kind of, as you mentioned, like a hereditary disease that caused all of the end-stage renal disease for the brother, and I think the father, or it's one brother, correct? One brother. Right.
That was just one brother.
Yeah. And or whether like these things are related. The fact that they're so young, it points towards like perhaps there is like a more hereditary component to it. But the things that you never want to miss, sounds like the CBC was normal, but again, like MAHAs as etiology of that, like TMAs as we talked about, glomerulonephritis. So making sure like, I'm curious to know, I know we have a urine protein, but if there was any blood in the urine as well, to make sure at times like some of these with like immunosuppressions and stuff can be we can stop the progression of it. But I agree with you, Zachariah, that I'm also worried about more about like a hyperaldo in this patient. And the things that I would want to make sure, again, like in every comers, the easy things to rule out is like post obstruction. So making sure you get your make sure you evaluate for urinary retention, getting a urine like an ultrasound of the kidneys. Like if there is like cystic diseases of the kidneys, the size of the kidneys sometimes is helpful to establish chronicity of the disease. So if this is something that has been going on for a while, or is this like an acute insult that we're trying to get of it, like, malignant hypertension can cause like kind of MAHA physiology as well. So I think like the kidneys require further investigation. In terms of like the autoimmune diseases, we're not really getting any flavors of like inflammatory that only and no like rashes, no nothing else that and it seems like it's like an elevated blood pressure and isolated kidney disorder. But I totally agree with you that the kidneys require further investigation. All right, so Suna, you.
So that's what we thought too. So we got a renal ultrasound and we were hoping that it would reveal some more etiology wise, but it was just, it was surprising bilaterally normal sized, and it had some bilateral renal parenchyma concerning for medical renal disease and just minimal stenosis of the arteries. So nothing really pointing toward like the renal cause of this hypertension. And as it was a little elevated, we trended the troponin, but it started to downtrend. And we were also concerned about primary aldo. So we wanted to do this, the aldosterone level, the renin level, and calculate the PRA level. But since his blood pressure wasn't too well controlled, we were giving him some ACE inhibitors. So we weren't able to get the 2-week washout period, but we did get some numbers. And there was a guideline that said if we can't really get this patient off of ACE inhibitors for 2 weeks, then we should just take the aldosterone level and take the fact that he's on ACE inhibitors into account. So this was taken during the trial of ACE inhibitor, the aldosterone level was 19, and the plasma and renin activity was 16.26. The normal level at the lab was between 0.6 to 4.3, so the plasma renin activity was elevated. And the aldosterone renin ratio was 1.2, so this was not supportive of the primary aldosteronism, where the ratio would be like over typically 20. So as we were getting these tests done, we got the urine metanephrine, the normetanephrine, and the metanephrines total. Yep. Yeah, so aldosterone level was a little elevated, but not, yeah. The renin was elevated too, which made the ratio not supportive. Was, yeah, the numbers and how we interpreted them. As for the metanephrines, we had for 26 urine metanephrine, it was 363, with the normal range being less than 92. For the urine normetanephrine, it was at 1,468, which the normal range should have been below 729. As for the metanephrines total, this was from the serum, that was 1,831, and the normal range was below 205. So we know that it's now not supportive of primary hyperaldosteronism and supportive of elevated catecholamines. So what would we order next?
Oh gosh. Okay. I'm starting to become quite out of my comfort zone here. So I'm definitely going to need some help. I think the first thing that's a knowledge gap for me that I'd want to ask is, in terms of KUB interpretation, I associate small atrophied kidneys with patients having long-standing CKD, and I'm just wondering, can you have CKD with normal-sized kidneys? I presume the answer is yes. But I'd wonder, is there sort of a limited differential for that? And I do wonder about potentially the polycystic kidney disease. Is there any reason that those kidneys are relatively larger than normal, even in patients with CKD? Just something I'm not aware of that I'm eager to learn about. I think the interpretation of renal and aldosterone levels in patients with ACE inhibitors, it has a lot of caveats to it. I briefly remember having to do it once for a patient quite a while ago. And I think I just remember that the cutoffs are a little bit lower than what we'll use if somebody's not an ACE inhibitor. And here it seems that the patient's aldosterone and renal ratios were really, really low, which seems to make the diagnosis seem to be quite unlikely. I think the fact that this patient has sort of the elevated markers of all of these catecholamines does really, really make me wonder about the diagnosis of a pheochromocytoma. But I know that there's also a lot of nuances in the testing for it. And I just wonder, it's quite unusual for a patient to have this sort of presentation as the first time of a pheochromocytoma crisis. I presume it could happen, but I would have really wondered, has there not been a prior history of sort of surges of catecholamines and the resultant symptoms of that? And then I think just the last thing, I've only ever seen one patient who had a pheochromocytoma, and he actually came in a status epilepticus and had a genetic disease, von Hippel-Lindau syndrome, that had caused him to have bilateral pheochromocytoma. So I know that's a genetic disease, but I really think the fact that this patient seems to have normal-sized kidneys, if that does really rule out most of the common causes of CKD that run genetically, then perhaps the fact that his brother has end-stage renal disease, as you said earlier, could be totally unrelated to this patient. So yeah, please teach. I'd love to know more.
Yes, Zakariyya, a really, really great points. And yeah, like a tricky case. Yeah. And similar to you, I haven't seen much cases of pheochromocytoma, but a few things like before we like I think more like whether this is like pheochromocytoma or not. I think like the other things to think about again is like kind of like malignant hypertension causing like kind of a like a microangiopathic. So I think the other thing that would be really, really helpful is like the trend of the creatinine. I don't know, Sune, you if the creatinine was like getting better or was it like stable or getting worse throughout the hospitalization?
So it was just not budging at 8, so we were very concerned about that too. And this patient wasn't getting a very regular follow-up with the hospital and his primary care. So the only creatinine number we had was 1.5 from 3 years ago and 8 at his arrival, and which stayed at about hovered and stayed about at 8 all the time for about a week that he was in the hospital. So that was one of the other reasons why we thought this cannot be just essential hypertension.
Mhm.
And yeah,
Yeah. Yeah, so I think like thinking a little bit, yeah, kind of, so I think like the few with these lab findings are interesting to consider. So kind of like thinking about few, there's like a genetic component to it. Oftentimes, like MEN2 syndrome, those MEN2, those things oftentimes, and if you want to think about like whether both brothers had kind of the same thing. As we all know, it's like a catecholamine secreting a tumor oftentimes in the adrenal medulla. The interesting thing about it that oftentimes like people can be asymptomatic. So I know we've like thought about like, oh, it is like episodic nature of feel, but oftentimes people can just present with like sustained elevated blood pressures. And oftentimes actually they can be like quite orthostatic. And I wonder like the symptoms that he had might have been related to it. And with the nausea and the vomiting, I know initially I have like the nausea I had like attributed to the headache, but could potentially be consistent. And the other things you want to worry about, like complications when they come in, and I think going back to like kind of the cardiac manifestation, the shortness of breath, like people as complications can have like uh, RCVS, if I remember correctly, Takasubu, like stress cardiomyopathy. These are also like common presentations. And the one thing that I'm curious about is like the AKI, is that uh, because like oftentimes like is that just kind of an end organ damage of just elevated blood pressure, and then the elevated blood pressure, it is maybe a field that we are thinking about. And with like pheochromocytoma in general, um, uh, we like oftentimes like you have like an adrenal tumor, so thinking about like whether this patient needs a CT abdomen imaging to see if we can see to see that. And um so that is like my thought is like, getting help with from the kidney doctors and our endocrinologists to see. And I agree with you that, that oftentimes like whenever I do the pheo studies, like I want an endocrinologist to review that. And as I get older in medicine, like going through endo studies when they come back, whether we're thinking about pheo or another condition, is actually a lot more nuanced than I thought when I was like in a medical school, and how they put it in the context of the patient and other factors. I always like learn so much. So I think it's like a very fair thing to run by endo. And I was like thinking about like, okay, if there's like a genetic component of it, what else could this be? We thought about like malignant hypertension. We talked about like hyperaldo that basically ruled out. Like often Cushing syndrome is another one to think about. Again, less likely in this patient. And we talked about like our TMAs and less likely a rapidly progressive glomerular with like a creatinine that is stable with no other factors. So I think like yeah, I would worry about feel here, and I would like want and those input. Zachariah, any other thoughts?
That was amazing. Yeah, I think just the one thing to add is that I think I've been sort of making this assumption that whatever is causing this patient's renal failure is also causing the hypokalemia. So, for example, we're talking about primary hyperaldosteronism. We're talking about sympathetic toxicity as the cause of hypokalemia. But it is possible that they could be just related to the patient having a renal disease. So the patient could have CKD from a cause and could also have renal tubular acidosis that can cause hypokalemia. So I think it'd be really interesting to know the pH of the patient, what their bicarb was, as that's actually something that I would have probably wanted to know earlier on, actually, and I should have asked for early on, when you're talking about primary hyperaldosteronism, as you would have expected somebody with that would have an inappropriately high bicarb despite having renal failure, if that was the cause, or if the patient has persistent acidosis, that might clue you into the possibility of RTA type 1 or type 2. But yeah, I think I definitely would want some input from endocrinology about how to interpret these studies. Yeah.
Well, and Zachary, I totally forgot to answer your question, like whether you can have a CKD with normal sized kidney. Yes, I think depending on the cause of the kidneys, and like the kidney size is not taken into account in the definition of CKD. Like smaller atrophic, as you mentioned, kind of points towards like a longer standing kidney injuries, but sometimes like kind of infiltrative diseases, sometimes like TMAs, all of those oftentimes have normal sized kidneys, so you can definitely have it.
Thank you.
Okay, yeah, I should have looked into more of the renal diseases and TME workups. Well, I've shared this case before coming to VMR with a few of my other study groups, and I feel like every time I present, I get a little more facets of this case that I haven't considered. So it's thank you for sharing more things that I should have considered. So yes, we were concerned about getting the CT of the abdomen, and with this creatinine at 8, we had the renals and the endocrinologist involved early on. which was very good because the CT abdomens did not show VO. It was just hyperplasia of the adrenal gland, and it was a very mild hyperplasia of the right side only, and the endocrinologist, and no one thought it was coming from there. So, any thoughts on what we would order next?
Oh gosh, I know you can have extra adrenal pheochromocytomas, but and I'm just wondering because it seems like all the markers are elevated, but again, I'm sure there's tons of nuances to interpreting them. Yeah, but I wonder because I think there's some sort of rule of tens. I don't know. I feel like I remember it being related to pheochromocytomas, like 10% are malignant, 10% are extra adrenal, and I don't
Yeah.
remember another 10, but yeah, I wonder if you need need to pan scan this patient uh, to find the mass.
Yeah. Oh my gosh. Yeah. The rule of 10. So you got it. So it was like 10% are bilateral, 10% of extra adrenal. And I often think about like paragangliomas as when I think about like extra adrenal and 10% malignant and 10% familial. So I think like in this case, I would probably think about like, oh, do any genetic mutations that we need to test for, if especially if the brother had the same one. Like I think about like the RET mutations for like MEN2, VHL disease, NFL1 can also be associated. Again, like he doesn't have the other presentations of that. And then there's like another gene that I forget that is associated, can be associated with PHO. And then like I think like whether this is like kind of the paragangliomas and how you evaluate for that, I have to look it up. But those are would be like my concern if we're still thinking like PHO is like probably the most likely diagnosis in this case. And again, I think like the hyperplasia is also like concerning to me. I have to look up to see like, oh, can we just like present with hyperplasia rather than like a discrete adrenal mass would be like the other question to look up at this point that I don't know the answer to. All right, Sina, you. What happened?
Yeah, that was one of the reasons why I was so glad that we had endocrinologists on board from the early on because we thought, okay, so maybe the hyperplasia of the adrenal gland is causing all these increased catecholamines, but our endocrinology said this level of hyperplasia shouldn't cause all this level of the catecholamine increase. So yes, they do love their hormones, and he suggested going for some of the MRIs of the skull base and the neck and the chest and the pelvis because along that line is where the other paraganglioma was, and we did find one at the cervical spine. So I was not aware that paragangliomas can be present other than para-aortic areas or the adrenal areas, but it can present anywhere in the sympathetic chain. So that was also very interesting. And so we started off with we contacted the general surgery for the workup for removing that paraganglioma, and we did order a genetic panel for the patient and the family members. So that's when our younger brother who got kidney transplant when he was 30 comes in, and he was also positive for the gene of SD. It was along the line of SDHB or
Well,
SDHC,
I
but it was
is the succinate dehydrogenase genes, right? Is it SDHX?
yes, those genes.
Okay.
So,
Mhm.
and another one of his brothers, he had a lot of brothers and sisters, and he was also positive for one of the mutations. So, I think that was pretty cool because he did not have hypertension at the point, but he was positive for the genetic mutation. So now we have a patient that we can keep an eye on so that he doesn't end up with another renal failure or this level of hypertension. So yeah, in the end, I learned a diagnosis that I wasn't aware of, and we were able to prevent possibly um, one of the younger brothers from getting another kidney transplant. So I know the numbers were very confusing and could have been other diagnoses, but the thing was during his hospital stay, he was getting a lot of medications to keep his blood pressure controlled, and he was a little dehydrated at his presentation, so that might have thrown off one of the electrolytes a little, and it was quite hard to get the numbers correctly because he was moved from the ED to the ICU, downgraded, and then upgraded a few times. So, yes, I do agree that it was a very confusing, and I know I'm seeing a lot of chat questions, but I'm not sure if I can answer much of them.
Oh gosh. Uh,
Any thoughts, Zakaria? What a case, Sunayu. Thank you so much for presenting. Was Zakaria, any reflections?
Yeah, I think so I just Googled this meditation now, which I've never heard of before. And I have one more reason to say that you should actually try to understand the Krebs cycle, because first you
Yeah,
need to really
exactly.
understand like lactic acidosis, and now you actually needed to fully understand pheochromocytoma pathophysiology. So fascinating. And I think Sunayu, I just wanted to say that we came to a really esoteric diagnosis at the end that's really rare. And I just love the way you presented it. You took us through bread and butter basics, headaches, secondary hypertension, renal failure, and it was expertly presented. So thanks a lot, and I really, really hope you come back and present again. And thanks to everyone for scribing teaching points and all the teaching, Sharmin.
Incredible discussion, Zakaria. You're awesome. That was like such a wonderful discussion. So many great pearls about like how to manage like hypertension, like, and also I love your point of thinking about kind of base rate of disease and your population before doing the $1 million workup. I think that's where really good reasoning helps. And yeah, very fascinating. I had heard of this mutations before, and I also quickly looked it up again. And yeah, and I think like there are different like SCHX, the X is like different subunits that can be affected. And it can cause like this hereditary paraganglioma pheochromocytoma type presentation. So now is like a good thing to remember that if you're worried about pheo, you can't find an adrenal. If you think about paraganglioma, think about this mutation. I think the SCHB is associated with mostly often abdominal and thoracic, and SCHD is often thought about like head and neck paragangliomas. So yeah, this is like such a fascinating case that again, like you presented beautifully, Sunayu, that helped us go through like, common things that we always worry about. And we ended in an esoteric diagnosis. However, what I would say, like, it can make such a big difference for these patients, and stage renal disease being on dialysis, it's challenging. It is, especially for people in their 30s, and being able to diagnose this patient and also like help into their family and keep a close eye on that and potentially preventing a worsening outcome for them. Like that is an incredible thing of how we practice medicine. So kudos to you and the team who's worked really hard and not giving up until you find a diagnosis for this patient. And I think like the way I'm putting this together is that especially has like kind of a genetic mutation leading to like kind of more sustained blood pressure, pheochromocytoma, and the elevated blood pressure most likely cause the AKI is like how I'm thinking about it. Is that how you guys thought about the AKI as well? That it was the most likely in the setting of just the elevated blood pressure?
So he wasn't getting much of medical follow-ups, and we thought with the hot weather and the level of his blood pressure, we thought it should go down, but it seems like he had this for a long time, and the 3 years ago it was 1.5, and we were wondering why that wasn't worked up because that was also a little too high for just a person with just mild hypertension. So we were thinking that maybe there is another cause, but it should have been just, it seems like the long-standing hypertension was doing much damage, and we did think about getting a kidney biopsy. I just saw a comment on that, but his um his uh his kidney function wasn't really doing too great. So, and what kind of good would that do was our also concern. So we kind of gave up on that idea. So we, yeah, tentatively we're thinking it was just a hypertension, very long standing.
Got it. Thank you so much, Sunil. Great job presenting. Hope you come back and present more cases. I learned a ton and so much to reflect on. Thank you so much, Zakariyya. You crushed it. What a pleasure discussing with you. Big shout out to David for subscribing, and Hans, to you for teaching points.
Yes, and I try to keep them very succinct. We had a patient, and he was 37 years old, presented with an acute headache, throbbing, and nausea. And the combination was already causing some red flags. And we were thinking about a hypertensive emergency because he presented with high blood pressure as well. And there was the fear of a ruptured vessel in the brain, an aneurysm, a sinus venous thrombosis, or in addition, hypertensive malignancies that could cause end organ damages. Now, the next question was the headache confined to the head, or was there a systemic disease? Our patient was 37 years old, so we are not considering essential hypertension as one of the reasons of his headache. It is more or less something primary systemic that could be going on if the head was shown to be without pathology, as was shown with the CT scan. So the 37-year-old possibly could have primary hypertension due to some systemic problem, and in his particular case, he stopped his hypertension medication. Was there withdrawal? Was there substance abuse? Was there something like in the body producing hormones like pheochromocytoma causing metanephrines, then hyperaldosteronism, or in females more the FMDH, which is fibromuscular dysplasia. End-stage renal disease with low potassium caused another problem for us, or thought, and here it is possibly hyperaldosteronism, or in his case with nausea, maybe there was GI loss. Further investigations then gave us a very important clue. The patient had PSH, paroxysmal sympathetic hyperactivity. High metanephrines were found, but at the same time, an abdomen, CT abdomen with kidney showed only a mildly elevated or mildly increased adrenal. Further investigation gave rise to the discovery of a paraganglioma, and possibly, as in our case, a genetic reason, which is in which explains the occurrence of the same disease in his siblings as well. It was found to be a genetic mutation of the SDH gene, a gene involved in the Krebs cycle. And at that point, I have some reading to do. Thank you very much.
Thank you so much, Hans, for the wonderful teaching points. Really appreciate it. And thanks, everyone. What a great case. Wow. Y'all are the best. We'll see you next time. Bye.
Thank you so much. Bye.
Bye.